Hello everyone, I am Dr. Kshitij Raizada. I am practicing as a Vitreoretina Retina UVA and ROP specialist in Bareilly, and I shall be discussing about central retinal vein occlusion, an ocular emergency where patients usually present with sudden onset painless diminution of vision, usually in one eye. CRVO could be ischemic or non-ischemic, with the ischemic variant being more severe, with the presenting visual acuity being usually less than 6 by 60. There is presence of RAPD, and on FFA, the capillary non-perfusion area is more than 10 disc diameters. CRVO is mainly a disease of the elderly, with the males being more commonly afflicted as compared to females. But in the recent times, what we have been observing is that even younger individuals who are less than 50 years of age, they are also being affected by CRVO. The etiology of CRVO includes hypertension, hyperlipidemia, diabetes mellitus, increased age, smoking, stress, inadequate sleep, obesity, junk food, use of oral contraceptive pills in females, raised intraocular pressure, vasculitis, hypercoagulable states like hyperhomocystinemia, vitamin B12 deficiency, myeloproliferative disorders. The pathogenesis of CRVO is based on virtuous triad, and all these etiologies lead to increased thrombogenicity of the blood, which culminates in CRVO. So patients usually present with sudden onset painless diminution of vision. And on fundus examination, what we see is a classic splashed tomato appearance with dilated and tortuous blood vessels. There might be swelling of the disc, macular edema, presence of cotton wool spots and hard exudates. And in the later stages, there may be presence of neovascularization at disc and at elsewhere, and the presence of vitreous hemorrhage. For diagnosis, we use OCT, which reveals in the presence of macular edema a distorted foveal contour with presence of intraretinal and subretinal fluid. FFA usually gives limited information in the acute stage because of obscuration of details by the presence of flame-shaped and non-blood hemorrhages. But what can be seen is vessel wall staining and disc staining in the late stages. But in the later stages of CRVO, FFA is very helpful because it delineates the capillary non-perfusion areas and the presence of NVD in NV. BP is mandated to be recorded at the time of presentation. Gonioscopy is very helpful during the follow-up of CRVO patients because CRVO is very notoriously known to cause neovascular glaucoma, especially 3 to 6 months from the date of presentation. The blood investigations include complete blood count, blood sugar, lipid profile, HbA1c, ECG, 2D echo, vitamin B12, serum homocysteine, coagulation profile. Systemic investigations hold more relevance in young patients because we need to hunt for the cause which has led to CRVO, because that cause is needed to be rectified so as to prevent further recurrences or to prevent the occurrence of any such thromboembolic event in the future. The management includes intravitreal anti-VEGF injections like ranibizumab, bevacizumab, or aflibercept. They decrease the macular edema, and this leads to increase in vision. Laser PRP is required to be done to the capillary non-perfusion areas so as to prevent the growth of neovascularization. In recalcitrant cases, intravitreal triamcinolone can be used, or Ozurdex, which is a dexamethasone implant, that can also be used. Patients having vitreous hemorrhage, they usually require surgical management with vitrectomy. And management of glaucoma is critical because, like I just mentioned, that CRVO commonly leads to neovascular glaucoma. So these are some of the references which you can use to gather more information regarding CRV. Thank you so much.